Hi, welcome to POC Nurse. My name is Gozi, and in this video, we're going to discuss acid-base balance and ABG analysis for the pulmonary section of the CCRN exam. What is the significance of acid-base balance? I'll tell you a story. When I first started out in ICU, I think my first week I was with my preceptor. We had a patient that was crashing, even though this patient was on all the pressors, maxed out on all the pressors. The doctors ordered an arterial blood gas, ABG. It was done. I think the patient's pH level came back as 6 point something, which is incompatible with life. This patient was essentially dying. We started sodium bicarbonate on this patient, and the patient started responding to the medications, and the patient didn't die on our shift. I don't know what happened to the patient, but we kept the patient alive. So that's the importance of this acid-base balance. It's it's only compatible with life in a very narrow range. Anything outside of it puts the patient in a precarious situation, kind of leans the patient towards death or dying. When we talk about acid-base balance, there are two main parameters amongst other parameters that we look at. We look at a respiratory parameter and a metabolic parameter. The respiratory parameter, like we talked about carbon dioxide being excreted through the lungs. We talked about the patient that was dying getting sodium bicarbonate. So there are two main parameters. One is respiratory and one is metabolic. The respiratory parameter is has to do with carbon dioxide. The metabolic parameter has to do with bicarbonate. So when an ABG is done, by the way, blood gas analysis can be done on venous blood and mixed venous blood as well as arterial blood. We're talking about arterial blood gases in this video. That is blood gas analysis that's done with an arterial sample. So when an ABG is run, there are several results that come back. The main ones are the pH. The pH tells you how acidic or basic uh, the patient's blood is. The normal value for pH that's compatible with life is 7.35 to 7.45. Anything below 7.35, the patient is acidotic. Anything above 7.45, the patient is leaning towards being alkalotic. The next thing we look at, and this is in no particular order, the next thing we look at is the partial pressure of carbon dioxide, the PCO2. The normal value is 35 to 45. Anything below 35, it means the patient is breathing out all of the carbon dioxide in his body. And if the patient is breathing out a lot of it, the patient must be breathing fast. Now, if the value is over 45 millimeter of mercury, it means the patient is retaining it. The patient is retaining carbon dioxide. Now, carbon dioxide can only be let out through the respiratory tract. So if the patient is retaining it, that means the patient must not be breathing normally. Patient might be breathing slower than usual. So we think, why is this patient breathing slower than usual? Maybe the patient did some drugs, that could inhibit the respiratory system. Maybe the patient is in pain. Maybe the patient has some kind of neuromuscular disease. Patient cannot move his diaphragm and is therefore not breathing properly. Now, we also look at the bicarb level on the ABG. So if the bicarb level, remember bicarb, if I didn't mention this before, bicarb is a more alkalotic substance, which is the opposite of carbon dioxide. Carbon dioxide is more acidic and bicarb is more alkalotic. Now, when the bicarb is low, when there is low base, when there's low alkaline substance, then the body tends towards being acidotic. When there's a lot of bicarb, when there's a lot of this alkalotic substance, then the body tends towards being more alkalotic. And when I say the body, remember, these are values we're getting from blood samples. So this is what is happening in the patient's blood. There are other parameters that we get from doing the ABG, depending on what we're looking for. So the ABG can tell us how well oxygenated the patient is. This is where we look at the partial pressure of oxygen on the ABG, that is the PO2. Normal PO2 value should be between 80 and 100 millimeter of mercury. The ABG also tells us what the patient's oxygen saturation is, that is the SaO2. That tells us how much hemoglobin is bound to oxygen. The normal value for this is 95 to 99% on room air. We also get this value from the O2 saturation probe we put on the patient's finger. It can also give us a indication of what the patient's SaO2 is, the patient's O2 sat is. So earlier we talked about how carbon dioxide and bicarbonate are the two substances that help with maintaining acid-base balance in the body, where CO2, that's carbon dioxide, is regulated by the lungs, bicarbonate is regulated by the kidneys. Then the pH tells us how acidic or alkalotic the blood is when we run an ABG. So let's talk about acidosis first. So where there's acidosis in the blood, pH is low. That means we have lots of hydrogen ions present. So an acid is basically a substance that gives up hydrogen ions. So if there are lots of acid in the blood, it's giving off lots of hydrogen ions. There'll be lots of hydrogen ions in the blood. pH will be low, blood is acidotic. But we're talking about acid-base balance, and we're going to jump into how the body regulates acid-base balance. So in a case where we have acidosis, the pH is going down, the body tries to compensate. The body tries to get the pH back to normal. How does it do this? Okay, so we have a lot of acid in the blood. What we can do is put in a dab of base or an alkali to see if we can bring the pH back to normal. So when there is acidosis due to a lot of carbon dioxide being retained in the body, this is respiratory acidosis. The kidneys will now compensate or try to compensate and bring the pH back to normal by creating bicarb, more bicarbonate, and putting it out into the blood. So when there's any respiratory problem, the metabolic side tries to compensate. So where we have respiratory acidosis caused by retaining a lot of carbon dioxide in the body, the kidneys will try to fix it. The kidneys will make more bicarbonate, put it out into the blood, and try to get the pH back to normal, right? In the same vein, when there's respiratory alkalosis, that means the lungs is we're pushing out a lot of the carbon dioxide out through the lungs. Therefore, the blood is now getting alkalotic. What happens? The kidneys again will respond to try to compensate. So when there's a respiratory issue in acid-base balance, the kidneys try to compensate. The opposite system, in a sense, will compensate. So when we have respiratory problems, the metabolic side will try to compensate. So when we have respiratory alkalosis, which means we have low carbon dioxide in the body, the kidneys will try to make less bicarbonate and dump more bicarbonate to try to get the body to be normal. I don't want to say acidotic, but to be normal, because right now the body is alkalotic due to not having enough carbon dioxide in it. And then the system that makes the alkali will get rid of more alkali in the body so that the pH can get back to normal. So when there's respiratory alkalosis, the pH is higher than usual, and CO2 will be low. All right, now, so we just talked about respiratory acidosis and respiratory alkalosis. These are two problems that originate respiratory portion of acid-base balance. And anytime there are issues with the respiratory side, the metabolic side tries to compensate. So when pH is low, because there are lots of carbon dioxide in the body, which means partial pressure of CO2 is high, then the kidneys will make more bicarbonate. So when pH is low, PCO2 is high, bicarbonate will start to go up to compensate for the low pH caused by the respiratory system. Same thing with respiratory alkalosis. In respiratory alkalosis, PCO2 is low. We don't have a lot of CO2 in the body. The kidneys will try to compensate by getting rid of bicarb to bring the pH back to normal. Now we're going to talk about metabolic problems, metabolic acidosis and metabolic alkalosis. So when we have metabolic issues, it's something to do with bicarbonate, something to do with the kidney side of things. So when we have metabolic acidosis, we are looking at the bicarbonate level. When we have metabolic acidosis, then bicarbonate is low. When this happens, again, the body tries to compensate. The opposite system is going to compensate this time, which is the respiratory system, right? So when we have metabolic acidosis, bicarbonate is low. When we have metabolic acidosis, bicarbonate is low. Therefore, the respiratory system will try to blow off CO2 to get the pH back to normal. So again, in metabolic acidosis, we have a low bicarb level, and to bring the pH back to normal, the respiratory system will respond by getting rid of an acid producing substance, which is carbon dioxide. So the patient will start to blow off more carbon dioxide to bring the pH back to normal. Now we're going to talk about metabolic alkalosis. So this one's easy. In metabolic alkalosis, pH is high. pH is high because there's a lot of alkali in the blood, which is bicarbonate. So in metabolic alkalosis, we have a high bicarb level, bicarbonate level. So again, the respiratory side is going to compensate and try to bring the pH back to normal. So what does the respiratory side do? Stop blowing off too much carbon dioxide. Start retaining carbon dioxide so that we can bring the pH back to normal. So we just talked about respiratory imbalances with the respiratory acidosis and alkalosis, and we talked about metabolic imbalances with the metabolic acidosis and alkalosis. There could also be mixed disorders in acid-base balance where it is an issue with the respiratory side and the metabolic side together. The exam doesn't really focus too much on that, so we're not going to focus too much on it, but it's important to note that you could have problems in both the respiratory side and the metabolic side at the same time. When you practice your ABG interpretations, you probably come across those. So it's important to have an idea of that in preparation for the exam. And we're going to talk about that in this video. So earlier we spoke about how the body tries to bring the pH back to normal depending on which side or which parameter is causing issues, maybe the respiratory side or the metabolic side. So when the body tries to bring the pH back to normal, it's a physiological process, that's a compensatory process. So therefore, when you look at the ABG initially and you see, oh my goodness, this patient is in respiratory acidosis because the PCO2 is high, and you do some therapeutic measures, you draw another ABG, or maybe you don't do any therapeutic measures and you just draw another ABG in 30 minutes or an hour, and you take a look and you see that, okay, the pH is is coming back to normal. Let's say it was initially 7 when you first drew an ABG, and you draw another ABG and now the pH is 7.2. But another thing to note was that the PCO2 was high on the first ABG, and the bicarbonate level was normal. Now you draw the second ABG. The pH is now 7.2. Let's say PCO2 is still at the same level, it is high, but now the bicarb level is going up. Let's say the bicarb level was initially 25, which the normal is 22 to 26. Initially it was 25. Now you look at it again, it's 30. It's 30 because the body is trying to compensate and bring the pH back to normal. So these are the things you look at when you're writing the exam, right? When they give you your ABG values. I don't remember if they did a before and an after, or if they just gave the values. But even if you just get the values, you can tell if it's respiratory acidosis, alkalosis, or metabolic acidosis or alkalosis, depending on if PO2 is affected or if bicarbonate is affected. When I say affected, I mean depending on which parameters are abnormal. If the CO2 is abnormal, we're talking about respiratory issues. If the bicarb is abnormal, we're talking about metabolic issues. Now, if we see that in a respiratory issue, the bicarb is starting to inch up and the pH is moving towards normal, then we see that it's a respiratory issue. The body is trying to compensate by increasing the bicarbonate level from normal to not normal. So, which means that when the body is trying to compensate or has even fully compensated, we can get a pH that is normal, but our two parameters, the respiratory and metabolic parameters, will be abnormal. So, in the case of respiratory acidosis, the partial pressure of carbon dioxide, the PCO2, will be high, and the bicarbonate level will also be high. In that case, we have a fully compensated acid base issue with abnormal respiratory and metabolic parameters. Again, the body can also correct an acid base balance. Now, the difference between compensation and correction is that when the pH is corrected, all of the other parameters will be normal. So the PCO2 will be normal and the bicarbonate level will be normal as well. In the case of compensation, the pH will be normal, but the PCO2 and bicarbonate parameters or values will be abnormal. So that is compensation versus correction. In correction, values are normal. In compensation, we have abnormal values with a pH that is at the normal level. I hope that makes sense. Let's discuss the anion gap. So first, what's an anion? An anion is a negatively charged ion found in the body, in the blood. If we have negatively charged ions, we should have positively charged ions. Those are cations. Now, the anion gap is useful when the body is in metabolic acidosis. So a good example of that would be when you have your DKA patient, patient that's in diabetic ketoacidosis. We measure the anion gap to see how the patient is responding to treatment. And the anion gap in the first place tells us that this patient is in DKA, amongst other things. So the anion gap is useful in kind of diagnosing what's wrong with the patient and directing treatment for the patient, and in also determining how the patient is responding to treatment. So, for example, this DKA patient, the anion gap will tell you, okay, this patient is in DKA. You start your treatment. As the anion gap closes or doesn't close, you can determine if your treatment is working or not working. So, what is the normal anion gap? The normal anion gap is between 5 to 15 MEQs per liter. And how do we get this range? So we get this range by subtracting the amount of positively charged ions in the blood from the number of negatively charged ions in the blood. So the positively charged ions are sodium and potassium, and the negatively charged ions are chloride and bicarb bicarbonate. So these are the ions that direct what the anion gap is. So remember, the anion gap will now focus mostly on the negatively charged ions. So anion, negatively charged ions. The positively charged ones are called cations. There are other ions that are not considered in this equation. Keep that in mind. So essentially, this equation is sodium plus potassium ions minus chloride plus bicarbonate ions. So these aren't the only ions in the serum, but these are the only ones considered when calculating the anion gap. So the significance of this anion gap is essentially trying to determine, okay, this patient is in metabolic acidosis, and this is how the patient is responding to treatment. Now, when we say this patient is in metabolic acidosis, we have to say or think about what is the anion gap then. The anion gap may be elevated or the anion gap may be normal. So if the anion gap is elevated, it means it's over 15. That means this patient is creating a lot of acids in their body, or has ingested acidic substances, or has ingested something that is being metabolized into an acid. This is when the anion gap is high. An example of this is when the patient is in DKA, like we said before, patient is making keto acids in their body. Another example is in methanol poisoning. When the patient ingests methanol, it gets metabolized into an organic acid called formic acid. These are just a few example. Another familiar example is in lactic acidosis, when the patient is in sepsis, or when the patient is in shock, or when the patient has ingested salicylates, the body makes lactic acid. So these are conditions where the anion gap would be high because the patient's body is making a lot of acids. Now, the anion gap could be normal and the patient would be in metabolic acidosis as well. How does this happen? So, this happens when the patient is losing a lot of base or alkaline substance from the body. So, if the patient is dumping a lot of bicarb, the patient will be in metabolic acidosis. We discussed this before. However, if the patient is in metabolic acidosis and losing bicarb, you'd think that the anion gap would be abnormal. But in the case of this kind of metabolic acidosis, even though the patient is losing bicarb, remember on the other side of the equation, we have bicarb and we have chloride. As the patient is losing bicarb, the body is compensating by retaining more chloride. So this is how come the anion gap is normal when the patient is losing a lot of base and is in metabolic acidosis. So also the anion gap can tell you what the cause of the metabolic acidosis is, like we mentioned, in the sense that it can tell you if this patient is in metabolic acidosis because they are gaining a lot of acids, making a lot of acids, or due to elevation of acid in the body, or that they are in metabolic acidosis because they are losing a lot of base, a lot of alkaline substance from their body. So this is where the anion gap is significant in acid base imbalance. I hope that made sense to you. It took me a while to grasp it, but essentially, the anion gap tells us that our patient is in metabolic acidosis, and why and how. Why? Because they are making more acids, or because they are losing a lot of base, a lot of alkaline substance from the body. So essentially, that's what the anion gap is all about. Moving on. Let's talk about some conditions where we have an increased anion gap. We have methanol or ethanol ingestion, like we talked about before, uremia, diabetic ketoacidosis, or alcohol ketoacidosis. Starvation can also be part of this. Aldehyde ingestion, iron toxicity, lactic acidosis, we mentioned this before already, and ethylene glycol ingestion, as well as salicylate intoxication. We talked about this earlier. So these are all conditions where we can have an increased anion gap with metabolic acidosis. Let's now talk about, on the other hand, causes of metabolic acidosis in the presence of a normal anion gap. So in this case, we have things like diarrhea. You have a lot of alkaline substance in the intestine. So a lot of diarrhea will cause metabolic acidosis in the presence of a normal anion gap. Another condition is when a patient's getting a lot of saline infusion, and problems with the kidneys will also cause metabolic acidosis in the presence of a normal anion gap. In this case, would have something like renal tubular acidosis causing metabolic acidosis when we have a normal anion gap. So now let's dive a little deeper into how the body compensates acid-base imbalances. So let's talk about acid-base compensation. So at one point, we talked about how when we have an imbalance with the respiratory side, the metabolic side will compensate. And when we have an imbalance in the metabolic side, the respiratory side will compensate. We also talked about correction and compensation. Now we're going to talk about just compensation. So, an acid base imbalance can be uncompensated, partially compensated, or fully compensated. So when it's uncompensated, we have the pH is abnormal. We have either the respiratory or metabolic parameter is normal. One is normal and the other is abnormal. Nothing is compensated. The patient is acidotic or alkalotic, and one of the parameters, be it the respiratory or the metabolic one, is normal while the other is abnormal. Nothing is compensated. The pH is abnormal. When we talk about partial compensation, it means there has been a change from the uncompensated imbalance to a situation where the acid base imbalance is heading towards being balanced. And then when we talk about full compensation, now the pH has gone from heading towards being normal to now being normal. It's going from imbalanced to balanced. So let's do one example. Um, you have a pH of 7.1. Is that acidotic or alkalotic? The normal value is 7.35 to 7.45 for a normal pH. So at 7.1, we have an abnormal pH. The pH is low, therefore the patient is acidotic. Now we need to find out, is this respiratory acidosis or is this metabolic acidosis? This is where we go look at the PCO2 and the bicarb levels. Now, our PCO2 is 55. What do you think? 55 is normal, abnormal? It is abnormal. The normal value for PCO2 is 35 to 45. So at 55, the PCO2 is abnormal, and the CO2 is the respiratory parameter we use in ABGs. Therefore, this patient is in respiratory acidosis. We now expect that the bicarb level will be normal. If the bicarb level is normal between 22 and 26, let's say it's 24, it means this acid base imbalance is not compensated, it is uncompensated. Now, let's move on to partial compensation. Now, we have this initial ABG with a 7.1 pH. We did another ABG. Now, the pH is what? 7.25. Is that fully compensated? No. Normal pH is 7.35 to 7.45. So at 7.25, we're heading towards the right direction towards a normal pH. Now we're going to take a look at our PCO2. It's still 55. Okay, our bicarb level should have changed because we have partial compensation going on. So instead of having a value of 24, now we have a value of maybe 29. So the bicarb level is going up, the pH level is trending towards normal, we have partial compensation. So we still have all abnormal values at this point. In partial compensation, we have all abnormal values. Now we're going to move on to full compensation. We do a third ABG. Now the pH is 7.4. It is normal. However, PCO2 remains abnormal at 50, and our bicarb level is now abnormal also at 31, but pH is normal. So here we have compensation, full compensation, not correction. For correction, all the values will be normal. For compensation, the pH level will be normal, but the PCO2 and bicarb levels will be abnormal. So this is where you have uncompensated acid-base imbalance, highly compensated acid-base imbalance, and fully compensated acid-base imbalance. So in uncompensated, we have two abnormal values, the pH and either the respiratory or metabolic parameter, which is the PCO2 or the bicarb. In partially compensated, they are all abnormal, the pH, the PCO2, and the bicarb level. In fully compensated, now the pH is normal, but the PCO2 level and the bicarb level are abnormal. But we have a normal pH, so we are fully compensated. And you can apply this example to respiratory alkalosis, metabolic acidosis, or metabolic alkalosis. The method, if you want to call it that, will apply to all of it when you're talking about uncompensated, partially compensated, or fully compensated acid-base imbalances. Earlier, we talked about how, we could also have mixed acid base disorders. We could also have combined acid base disorders. Um, these are seldom, you might not have them on the test, but it's something that's good to know. So when you have a combined acid base disorder, um, it means we have kind of the same abnormality going on. So we have combined respiratory and metabolic acidosis, or we have combined respiratory and metabolic alkalosis. On the flip side, when we have a mixed acid base disorder, in this case, we have not like the same kind of respiratory and metabolic acidosis. In this case, you could have respiratory acidosis and you could have metabolic alkalosis. Okay, now we're going to do an assessment of an ABG, a systematic assessment. We want to be able to systematically go through this question and answer the and get the answer fast so that you can keep it moving when you take the exam. So first, when you get your ABG result on the exam, of course, you're going to have a pH value, you're going to have a PCO2 value, and you're going to have a bicarb value for the most part. So when you get those numbers, first off, you want to take a look at your pH. Anytime I see like an ABG problem, first off, what's the pH? Is the pH, is it acidic? Is it alkaline? Anything less than 7.35, okay, we have acidosis going on. Anything greater than 7.45, okay, we have alkalosis going on. Now, is it respiratory or is it metabolic? That's the next question. Look at your PCO2. If it is normal, you've ruled out all respiratory issues. This is not a respiratory anything. You go on to your bicarb number. If it's abnormal, then you are looking at a metabolic acidosis, or you're looking at a metabolic alkalosis. So always first thing, what's my pH? Your pH will tell you if you're alkalotic or acidotic, right? Once you know what your pH is, now you want to know, is this metabolic, is this respiratory? You look for your respiratory parameter. Is it normal? Then if it's normal, you don't have respiratory anything. Look for a metabolic parameter, which is bicarbonate. Is it abnormal? If it's abnormal, you have a metabolic something, alkalosis or acidosis. I hope that makes sense. Next, your question might be something about compensation. So now you want to determine if this patient is compensating, uncompensated, fully compensated, or partially compensated. Remember, when we have full compensation, we have a normal pH and two abnormal other values, which means the PCO2 is abnormal and the bicarbonate is also abnormal. When you do your systematic assessment of your ABG, you also want to check to see if you have a mixed disorder, and you want to check for oxygenation. Remember, when we do an ABG, we can check for ventilation. What's the PCO2 value? The CO2 will tell you how adequately the patient is being ventilated or not. You check your PO2. When I say PO2, I mean your PaO2, PaCO2. You check your PaO2. Your PaO2 is the amount of oxygen that's dissolved in the blood, right? That will tell you how oxygenated the patient is, if gas exchange is occurring very nicely. And then you can also check for, of course, acid base imbalances with your ABG. Now let's do some numbers. I'm going to throw out some numbers. I want you to think about, is this acidotic? Is it alkalotic? And then next thing, is it respiratory or is it metabolic? And then we could also talk about, is it compensated? Is it not? Okay, first one. Our pH is 7.5. Our PaCO2 is 30. And our bicarb level is 25. So let's do this systematically. We said the pH is 7.5. It is over 7.45. So this patient is in alkalosis. Now, is the patient in respiratory or metabolic alkalosis? Let's find out. We said the PaCO2 is 30. The normal PaCO2 is 35 to 45. So this patient has a low PaCO2, right? Okay, so let's not call it respiratory alkalosis yet. Let's make sure that our bicarb level is normal. If the bicarb level is normal, then we can say that this is respiratory alkalosis. We already said the bicarb is 25. The normal value is 22 to 26. Therefore, this bicarb level is normal. That means that this patient is in respiratory alkalosis. Our pH is alkalotic, our respiratory parameter is abnormal, while our metabolic parameter is normal. So this patient is in respiratory alkalosis and it is uncompensated because the pH remains abnormal, the respiratory value remains abnormal, and our bicarb is normal. For this to be partially or fully compensated, the bicarb level has to start trending down. It has to trend down so that we can get the pH to 7.35 or 7.45. It's not happening yet. All right, let's do one more and we'll call it a day for today. All right, so we have a pH of 7.25, a PaCO2 of 65, and our bicarb level is 30. Okay, so our pH is 7.25, acidotic right there. Now, is it respiratory or is it metabolic? We have to check our parameters. Our PaCO2, we said, is 65. That is way above the normal of 45. The normal is 35 to 45. We have 65. That is way high. Therefore, we must be looking at respiratory acidosis here. But first, let's take a look at our bicarbonate level and see what it is. Our bicarb level is 30. It is trending up. So it would seem that we have respiratory acidosis going on here that is partially compensated because our bicarb level is going up, is higher than usual at 30. We will stop here for this video. I hope you found it helpful. We talked about acid-base balance in the body, in the blood, and the importance of it. It has to be within a certain range to be compatible with life. I read somewhere that at a pH of 7 point, what was it? 7.6 and 6.8, we are looking at death. I'm not sure. I have to double check. But the thing is, severely abnormal acid base balance is not compatible with life. So it's important to help keep the patient's acid base balance as close to normal as possible to keep the patient alive, basically. We talked about the two major parameters that are used to determine acid base balance. We talked about the respiratory parameter, which is the CO2. We talked about the metabolic parameter, which is the bicarbonate. CO2 is controlled by the respiratory system, and bicarbonate is controlled by the kidney in metabolic processes. We talked about the anion gap. We talked about compensated, uncompensated, partially compensated acid base imbalances. We talked about the difference between correction of an acid base imbalance and compensation of an acid base imbalance. I hope you found this video helpful, and I'll see you in the next one. Bye bye now.